Hello everyone. Today let's explore the importance of human touch in healthcare in the age of generative and agentic AI. How do we protect trust while automating everything else?
Healthcare is one of the most human professions on earth. It's also one of the most system-heavy, paperwork-heavy, and interruption-heavy industries we've ever built. And that's why the conversation about generative AI and agentic AI in healthcare feels so emotionally charged. Because this isn't just about technology. It's about what happens to the relationship between a patient and the people caring for them when machines can write, speak, summarize, recommend, and now increasingly act.
A few years ago, AI in healthcare often meant behind-the-scenes analytics, risk scores, imaging models, population health dashboards. Today, GenAI sits right at the surface. It drafts clinical notes, summarizes charts, generates patient instructions, answers questions, triage chat, prior authorization drafts, claim support, scheduling support. And agentic AI takes it a step further. It doesn't just suggest the next step. It can execute the next step, like coordinating appointments, sending messages, routing tasks, updating records, and triggering workflows across systems. If we do this well, AI could give healthcare back its humanity by reducing administrative burden and creating more time for listening, explaining, comforting, and making careful decisions. If we do it poorly, AI could become the next layer of friction, turning care into a set of automated interactions where nobody feels seen and nobody feels responsible. So, in this video, we're going to answer a simple question that is not simple at all. What does human touch mean in healthcare, and how do we preserve it even as Gen AI and agents become embedded into every workflow? Let's start by being honest. Many patients already feel the human touch slipping away, and it's not because clinicians don't care. It's because the system is overloaded. Appointments are shorter, clinicians spend hours documenting, nurses fight through inboxes and callbacks, care coordinators juggle dozens of referrals and authorizations, patients bounce between portals, phone transfers, and confusing instructions. Families become the project managers of care. That's why so many health system leaders and clinicians are drawn to AI right now. Not because they want to replace people, but because they want their time back. Many industry transformation agendas emphasize practical outcomes like easing workforce burden, improving patient experience, supporting interoperability, and redesigning workflows, rather than chasing novelty for its own sake. Those priorities show up repeatedly in healthcare innovation programming and digital transformation conversations, including themes around workforce readiness, patient-centered innovation, data exchange, and operational modernization. But here's the catch. The more efficient the system becomes, the easier it is to accidentally remove the very moments where human connection matters most. So we need to define human touch in healthcare in a way that is operational, measurable, and designable. Human touch in healthcare is not just friendliness. It's not a warm tone in a message. Human touch is a bundle of 5 things. It is trust, meaning patients believe the system is acting in their best interest. It is empathy, meaning patients feel understood, not processed. It is clarity, meaning people understand what is happening and what to do next. It is accountability, meaning someone owns the outcome and will not disappear. And it is dignity, meaning patients feel respected, especially when they are vulnerable. Now let's place Gen AI and Agentic AI into that picture. Gen AI can generate language that sounds empathetic. It can create clear explanations. It can translate, simplify, and personalize instructions. That can be a huge win, especially for health literacy and accessibility. But agentic AI introduces something entirely new. It can take action. It can book, submit, reorder, route, message, reconcile, and update records. And in healthcare, actions are where harm can happen. So the core design challenge becomes this. How do we automate tasks while preserving the human relationship? And how do we automate actions without eroding accountability? To answer that, let's walk through what goes wrong when human touch disappears, and then what good looks like when AI is used responsibly. The first failure mode is what I'll call the invisible clinician problem. A patient interacts with an AI assistant in a portal. The assistant gathers symptoms, suggests next steps, offers education, and maybe even drafts a plan. If the patient does not clearly understand whether a human clinician reviewed it, trust starts to wobble. If something goes wrong, accountability becomes blurry. The fix is not banning the assistant. The fix is clarity by design. The patient should always know when they are interacting with AI. The patient should know whether a clinician has reviewed the outcome. The patient should have a clear talk to a nurse or request clinician review path. And when the clinician does step in, they should see a summary that includes not only the clinical facts, but the emotional context, what the patient is worried about, what they didn't understand, what they asked repeatedly. That's human touch. Not the clinician typing every word, but the clinician being present at the right time with the right context. The second failure mode is what I'll call the automation wall. This is when AI becomes the gatekeeper. A patient tries to reschedule, the agent says no. A patient asks why their medication is delayed. The agent gives a generic response. And after a few loops, the patient realizes there is no person, or there is a person, but the path is intentionally hidden. That is where AI becomes dehumanizing, not because it exists, but because it is used to deflect. The fix is escalation as a product requirement, not a policy statement, not a hidden option, a design requirement. Any patient-facing AI system should include a frictionless path to a human with service-level expectations that match clinical risk and patient vulnerability. And the system should detect when escalation is needed, not just when it is requested. When language suggests fear, confusion, worsening symptoms, medication errors, or potential harm, the system should stop trying to be clever and rude to a human. The third failure mode is what I'll call synthetic empathy. This is when the system sounds caring, but the care is not real. It apologizes with perfect wording while denying help. It uses warm language while providing no solution. It pretends a relationship exists when it does not. Patients are extremely sensitive to this. People don't mind automation when it's honest. They do mind being emotionally managed by a system that won't take responsibility. The fix is to treat empathy as a clinical and ethical function, not a copywriting style. AI can help clinicians communicate more clearly. It can help translate medical terms. It can help draft messages that are respectful and understandable. But the care plan, the difficult conversations, the informed consent, and the decisions with consequences must be owned by humans, and the system should never pretend otherwise. Now, let's switch to the clinician side, because human touch depends on clinicians who have the time and mental space to be human. One of the most promising uses of GenAI in healthcare is documentation support. If AI can draft notes, summarize the chart, capture encounter details, suggest orders, and reduce the after-hours pajama time that burns people out, that can improve both workforce well-being and patient experience. But here's the human touch trap. If organizations use documentation AI purely to increase volume, shorten visits further, and cram more patients into the day, the extra time will not become human touch, it will become throughput. So success needs to be defined properly. The goal should be that clinicians spend more of the visit looking at the patient, not the screen. The goal should be better continuity, better recall of patient goals, fewer missed details, fewer duplicative questions. The goal should be reducing cognitive load so clinicians can listen more deeply. And importantly, the clinician must remain the author of the record. AI drafts, humans verify. The medical record is not a marketing document. It's a clinical artifact with ethical consequences. Now let's talk about agentic AI in operations, because this is where healthcare can quietly lose human touch without realizing it. Agentic AI will be used to manage scheduling, referrals, authorizations, follow-ups, discharge coordination, care gap outreach, and revenue cycle tasks. These are not glamorous workflows, but they are exactly where patients often feel abandoned. Think about the patient experience around a referral. The clinician says you need to see a specialist. Then the patient waits, calls, gets routed, leaves messages, nothing happens. Or the specialist office says they never received the referral, or the prior authorization is pending, or the imaging center requires different paperwork. This is not a clinical problem, it's a coordination problem. And it's an empathy problem because the patient feels like no one cares when in reality the system is just fragmented. Agentic AI can help here by tracking the workflow end to end, detecting stuck steps, requesting missing documents, and proactively updating the patient. That could be a real human touch multiplier because it reduces uncertainty and restores a sense that someone is paying attention, but only if the agent is accountable. So here is a practical model for safe agentic AI in healthcare. Think in levels of autonomy, like a driver's license. Level 1 is read-only. The AI retrieves information, summarizes, and recommends. Level 2 is draft mode. The AI prepares orders, messages, referrals, or authorizations, but requires human approval. Level 3 is constrained execution. The AI can execute within strict guardrails, like rescheduling within approved windows, sending standardized follow-up instructions, or routing tasks to the right team. Level 4 is broad execution, which should be rare in clinical contexts and requires extensive monitoring, clear governance, and strong auditability. Most health systems should live mostly in level 1 through 3 for a long time, especially for patient-facing or clinically impactful actions, because trust is easy to lose and hard to rebuild. Now we need to address the big governance question, because human touch in AI-driven healthcare is ultimately a governance outcome. Governance isn't just a committee. Governance is what ensures the system remains safe, fair, and accountable at scale. And in the age of Gen AI, governance needs to cover more than model performance. It must cover workflow behavior. Here are the governance questions that protect human touch. Do we disclose AI involvement clearly to patients and staff? Do we have consent and opt-out paths where appropriate? Do we have clear escalation pathways and response times? Do we define who owns the outcome when AI participates? Do we log what the AI did, what data it used, and what actions it triggered? Do we have ongoing monitoring for errors, bias, drift, and safety events? Do we have a process to pause or roll back a feature quickly when something breaks? Healthcare transformation programs increasingly emphasize readiness, literacy, and operational governance as essential because tools alone don't create value. Adoption, workflow integration, and trust do. These themes show up strongly in healthcare digital transformation discussions, including the need for workforce readiness, leadership alignment, and usable, safe, interoperable systems rather than isolated pilots. Now let's talk about the workforce, because human touch is delivered by humans and those humans need support. AI literacy in healthcare is not optional. If staff don't understand how these systems behave, they will either overtrust them or avoid them. Overtrust can lead to missed errors. Avoidance can lead to shadow workflows and unsafe workarounds. AI literacy means staff know when to verify, they know how to check sources, they recognize hallucinations and overconfidence, they know how to document AI use, they know how to report issues, and they know how to protect patient privacy. This is especially important for nursing and frontline teams who are closest to patient experience and operational reality. If the technology does not match their workflow, it will not produce human touch, it will produce friction. Now let's bring in the patient perspective, because in the end, the patient decides whether the system feels human. Patients are not asking for a purely human system. Many patients want convenience. They want faster answers. They want simpler instructions. They want fewer phone calls. They want more transparency and less waiting. So AI can absolutely improve patient experience when it is designed around patient needs. For example, GenAI can help produce after-visit summaries in plain language. It can generate instructions in multiple languages. It can explain medication schedules. It can answer common questions about preparation for procedures. It can guide a patient through what to expect after surgery. But in every one of those examples, there must be guardrails. Medical guidance must be aligned with clinical protocols. Patient instructions must be reviewed and validated. The system must avoid giving false reassurance. And when uncertainty is high, it must route to clinicians. This is where intentional friction becomes important. In technology design, we usually try to remove friction everywhere. In healthcare, you need the right friction at the right time. If an AI agent is about to trigger a medication change, that should require human confirmation. If it is about to send a message about a serious diagnosis, that should require clinician review. If it detects potential emergency symptoms, it should prioritize urgent guidance and escalation, not a casual chat flow. If it is uncertain, it should not improvise, it should hand off. Intentional friction is how you keep human touch in the moments that matter. Another important principle is continuity. Human touch increases when patients feel known. AI can actually help with continuity by summarizing the patient's story consistently, so patients don't have to repeat themselves. It can track goals, preferences, and social context. It can highlight that the patient struggles with transportation, or that they prefer phone calls, or that they are caring for someone else, or that they have anxiety about procedures. But continuity becomes harmful. if it becomes surveillance. So the rules should be simple. Use personal context to reduce burden and improve care, not to manipulate behavior or optimize revenue. Respect boundaries, minimize data, protect privacy, make it clear what is being used and why. Now, one more critical area, equity. Healthcare disparities are real, and AI can either reduce them or amplify them. If your AI tools are trained on biased data or if they are deployed in ways that privilege digitally fluent populations, the human touch gap will widen. People who can navigate portals will get more support. People with limited internet access, limited health literacy, language barriers, disabilities, or distrust of institutions will be left behind. So the human touch design requirement must include accessibility, multiple languages, multiple channels, easy human escalation, clear explanations, support for caregivers, and an operating model that does not punish patients for being complex. Now let's close by turning all of this into a practical checklist that leaders, clinicians, and builders can actually use. If you are deploying GenAI or Agentic AI in healthcare, ask these questions. What are we automating and what human relationship are we protecting? Where does the clinician remain the author and final decision maker? Where does the patient have meaningful choice and clear consent? How does escalation work and how quickly does a human respond? How do we monitor safety, bias, and error patterns over time? How do we ensure an audit trail for AI actions and recommendations? How do we measure success beyond cost, including trust, safety, burnout, and experience? How do we train staff so AI becomes support, not chaos? If you can answer those questions clearly, you are not just adopting AI. You are preserving humanity while modernizing the system, and that is the real opportunity in this era. Gen AI and agentic AI are not the end of human touch in healthcare. They can be the reason human touch returns because they can absorb the administrative overload that has been draining clinicians and confusing patients for years. But that outcome is not automatic and will only happen if we make it a design goal, a governance goal, and a leadership goal. Automate the paperwork, protect the relationship, keep accountability visible, build escalation that works, measure human experience, not just productivity, and treat trust like the most valuable asset in healthcare because it is. Because in healthcare, technology is never just technology. It becomes part of how people experience safety, vulnerability, and hope. And that means the human touch is not a nice-to-have feature. It is the product.
Thank you for watching. If you like this video, please like and subscribe to the channel. Hope to see you in the next video.